Okay, it's now 2 o'clock, so we're gonna get started. Thank you everyone for coming back. I hope you had a nice break. I see Dr. Gambacorta is all ready for the Bills game after this as well, and Dr. Perkins has also taken time out of his Saturday at the CDCA annual meeting. So we are just going to introduce both of you very quickly, and then we will get started with our presentation. So thank you to our speakers and for our students for being here.
A native of Buffalo, New York, Dr. Gambacorta currently serves as the Associate Dean for Clinical Affairs and a Clinical Associate Professor at the University at Buffalo School of Dental Medicine. He graduated from the School of Dental Medicine in 1993. Dr. Gambacorta has been very involved with organized dentistry over the course of his career, holding multiple positions in the 8th District Dental Society and NISDA. Currently, he's the Vice President for the 8th District Dental Society, as well as the Chair of the Council on Dental Education and Licensure. Additionally, Dr. Gambacorta serves as an examiner for the Commission on Dental Competency Assessments and serves on the Patient Ethics Advisory Committee of ADEX. He has been the coordinator for the clinical licensure exams at Buffalo since 2012 and worked on developing the ADEX curriculum integrated format.
And Dr. Perkins served as the CDCA board chairman from 2015 to 2019. Dr. Perkins served on the CDCA board of directors as a dental member at large before being elected as vice chairman and is presently the chairman of the board of directors. He also represented the American Association of Dental Boards for 4 years on the Commission on Dental Education and Licensure, and recently completed a 4-year term on the Joint Commission on National Dental Examinations. While on CDEL, Dr. Perkins served on the ADA expert panel on oral cancer and the CDEL committee charged with developing a part 3 of the national boards that would eliminate patients from dental licensure examinations. So please join me in welcoming Dr. Gambacorta and Dr. Perkins. I think you're muted, Dr. Gambacorta. Still muted. Let's see if I can unmute you.
Does that work? Can you guys hear me now? Okay, great. Okay, thank you. Yeah, I couldn't unmute it, so I'm sorry. So hi, everybody. How you doing? Hope all is going well. I don't know if I can't see the presentation. Let's see if we can go back that way. And we can start. So I'm sure some of you are watching the game. I have my kids over here watching the game, so we're having a good time. And it's actually sunny in Buffalo today, which is a total bonus. Did the presentation come back up? Because I don't have it on my end. Okay, you're doing it great. Thank you. So really just a few things before we start. I can't see the presentation, but once we do, let's see. There we go. Okay. So kind of going over this, I really want to go over a couple things quickly. Dr. Perkins has some things to say. And I want to just basically tell everybody that we're looking at doing this basic kind of review of the presentation of the material. There's a lot more in depth. There's a lot of material that's online. The testing agencies, as well as the American Dental Association, as well as ADEX, provide a lot of material online. And of course, your state dental boards. And we're going to talk a little bit about state dental boards as we move through this. But today, we're going to talk a little bit about the relative history. We're going to talk about the current pathways and pathways. There's a lot of different ways you can gain licensure in a different jurisdiction. We're going to talk about some things that are happening with licensure now, and Dr. Perkins is certainly going to expand upon that a little bit. And then we hope for some good discussion at the end of both our presentations. Next slide. Okay. So one thing I would talk to everybody about is a live patient. I've always talked about this at a lot of meetings I go to, and it always drives me insane to hear the words live patient. Patients are alive by definition. So this is one of my little pet peeves, and I always throw that in. So what we try and refer to it as the patient-based examination. So as you start with the state boards of dentistry, they're agencies of the state government created by the state legislature. And some of the things that the state board of dentistry does is establish qualifications for licensure. They issue license to qualified individuals. They establish the standards of practice and conduct. They take disciplinary action when necessary, and they promulgate the rules to enable the board to perform its duties. The state dental board is the most appropriate agency for you to contact to receive the most current information about what the requirements are to be licensed in that particular state, the State Dental Practice Act, or any other licensure related information. And I can't really stress that enough. And we're going to kind of go through a map of the United States, and I'll show you some of the differences and the importance of really going through your state board of dentistry on where you want to go and looking at things. One thing I will say is, compared to when I was graduating from school, a lot of us kind of stayed where we were born, and a lot of people in my class ended up staying in Buffalo. And one thing, now there's a lot more transients. People are going all over to do programs. People have significant others from different states and different places. So a lot of people are moving around a lot and changing locations. So one thing to consider as you're looking at license, and the portability, of course, has always been a longstanding issue. So the longstanding issue I'm referring to with this slide, though, in particular, is about the getting changes in the licensure process. So state dental boards have been very reluctant to make changes. Testing agency autonomy. Everybody wants to kind of run their own thing and do their own things, and they've done that traditionally for a very long time. So that's also been some of the difficulty in making real significant changes. Even though now that's some of the things that are really taking place, in my opinion, are really significant changes. The validity and ethical considerations to changing from a patient-based examinations, and the elimination of the clinical licensure exams, of course, endorsed by the ADA, ADEA, and of course, ASDA, and many jurisdictions as well in New York State, being the first state in the country to mandate that someone who wants to be licensed in New York State participates in a residency program. So just the ASDA policy is, okay. The ASDA policy, as you guys know, I'll go through this really quickly, is you wanted to eliminate the patient-based exam. You wanted something that's universally accepted and standardized. And it's a valid and reliable exam, obviously, reflective of the scope of current practice. And so in the initial licensure options, you have a couple things going on. You have the tradition for the patient-based exam. You have the traditional based exam where you can bring in a patient to a licensure site. So NYU may be holding an exam, and say you're a student at Case Western Reserve and you want to go and take the exam at NYU. You can do that. They have certain exams in which students are eligible to go to different institutions to take the exam. The curriculum integrated format, which we helped create at Buffalo in collaboration with CDCA and ADEX, and the American Dental Association and NISDA. Here, you have to have, the patient has to be a patient of record. They have to have an established treatment plan within the school in which the patient is being treated, and the student has to be a student and or resident at Buffalo and some of the other schools that still run the CIF. Some of the other alternate pathways are going through a GPR and an AGD. You can take the Dolosky, which is offered by the American Dental Association. Some states will allow the portfolio examination. And this one hasn't been really widely recognized, but something that there's been a lot of significant effort in developing and looking at is the portfolio exam. And some states take the Canadian OSCE. You can see the states here, and I took this information from the ADA website. The states in green accept an alternate pathway, and the states in yellow still require a single encounter procedure-based patient examination. So alternate pathways, here's some of the states and some of the differences. And I would want you to just make sure you look at the differences between there's options and requirements in certain states. So what we're trying to do, obviously, as licensure starts to evolve and the pathways to licensure evolve, is we want to give more options to the students. And I think that's something that with the obviously the COVID pandemic, we've been very fortunate in far in looking at the licensure aspect of things, that's really helped propel some real significant change that I think is extremely beneficial to the students. New York requires completion of an accredited postgraduate program. California, Colorado, Minnesota, and Ohio offer licensure applications the absence of completing a PGY1 in lieu of taking a clinical exam. Washington has the option for taking a PGY1 completed in the state in a specific setting. So they have specific rules on where you can take your residency. Some states, like say these states I listed above, they're allowing you to take a residency program in almost any state. Washington's going to be a little bit more specific in what they do. Delaware requires completion of PGY1 and a state-specific clinical exam. They're the only state that requires a state-specific clinical exam. And then Alaska, Colorado, Indiana, Iowa, Oregon, and Washington offer an option to complete the Dulosky. And this has definitely grown in favor and popularity since it was first released a little bit ago. So the 8X exam, as many of you probably already know, consists of several different aspects. And really, the goal of the 8X exam is to enhance portability across the United States. And you have a diagnostic skills exam. You have a restorative, which is an anterior posterior restoration. You have a prosthodontic section, endodontic section, and a periodontic section, which is optional in certain jurisdictions. So again, you check with your state dental board. They would be able to give you the information on if the periodontal section is necessary to gain licensure in that jurisdiction. The patient-centered CIF, we talked a little bit about that. It's a modification of the traditional licensure exam. It enables the focus of the exam to shift from the candidate to the ethical treatment of the patient. This was really widely accepted when it first came out, and it was thought of at the time as the best way to continue using patient-based examinations. Now with the development of the CompeDont tooth and some of the other things, we're going away from patient-based experience examinations. As I said, one of the things with COVID, that was a big push and a big driver in moving that forward. Okay. Oh, let me go back. So one thing with the CIF that I thought was one of the most key components, now to only touch upon this quickly, is treatment must be rendered on a patient of record as part of a sequenced treatment plan. What we used to have in the traditional exam format is you'd have a patient that would have a large DO carious lesion, say on tooth number 14 that required endodontics, but the patient needed a DO on number 28 that qualified for the exam. In the traditional model, the patient would be allowed to sit for the exam and have 28 DO completed while 14 needed endodontic care. So with the CIF, we kind of reversed that. The patient wouldn't be eligible to sit for the exam unless the acute need of doing number 14, initiating that endodontic treatment, would be started. So some of the really key features of that, which I think are really important. So looking at the CompeDont map, this came from the CDCA website. You can see a lot of states have these bronze or gold circles in them. Those states permit the non-patient restorative exam, which would be the class 2, class 3 typodont exam and restorative. You can see a few states, Nevada, Wyoming, Oklahoma, New York, Delaware, and Georgia at this current time do not take the option of using a typodont tooth. You have to continue using a patient-based examination. So one thing I want to say too, as I add to this, is that it's a dedicated and focused collaborative effort. I think we missed a slide actually. Can I go back one? I can't seem to control this. Let's go back a couple. Okay, going back to the interactive map real quick. So what I like students to do is when you want to look at the interactive map, what you can do is you can actually click on the little gold dot that's on the map. It'll give you all the certain different requirements that the state requires for licensure in looking at that particular state. So you can look at Texas, Nevada, and Georgia here are the states I just kind of selected off. I just took screenshots after I hit that little dot. And you can see here, Georgia, they're going to be accepting the 8X exam after January 1 of this year. So as of right now, the state of Georgia accepts the exam. If you would have tried to apply for licensure before January 1 of 21, you would have had to have some other different requirements to get licensure in Georgia. So one thing I've learned through doing this in working with the licensure exam, I've met some incredible people. I've worked with some incredible students who have really helped in moving the licensure situation forward. It's been a real dedicated and collaborative effort to get this done. You can see some of the agencies I listed there that have helped move this process along. And I think as obviously COVID has come in and other things, there's been a big push in trying to really alleviate some of the stress and anxiety that the licensure exam brings to the student body in coordination, especially because you guys are trying to finish off your D4 year, finish those requirements, trying to get this exam done. Obviously, many of you are moving to different locations and going into programs. People are getting married, people are having children. So the licensure exam, a lot of these factors have really helped move it along in a very positive way. So I'm going to turn it over now to Dr. Perkins. And what we'll do is we'll answer some questions, obviously, at the end of his presentation. And if everyone has any questions, I'll be responding to questions throughout Dr. Perkins' presentation in the chat box. Thank you very much.
Dr. Perkins, I just gave you remote control, so let me know if you're able to control that. We can't hear you.
Dr. Perkins, are you connected to audio? We don't hear you, but it also does not look like you are muted. Perfect. Now we can.
These things. Alyssa, are you going to control this, or can I control it?
Yeah. If you'd like to control it, you have control, but if not, I can do it.
Basically, I'm pinch hitting for my dear friend, Dr. Guy Champagne. He was supposed to be doing this. He has a medical issue, so I'm stepping in for him. He's been a good friend of mine. But I'm going to be talking later. Guy Champagne is basically the genius behind the CompeDont tooth, which you've probably heard about, the CompeDont tooth, which changed everything. So if you could go to the next slide, some of what I'm going to talk about, Joe talked about, go ahead. The CompeDont slide was essentially, the CompeDont tooth was actually being developed before COVID. It was not developed in response to COVID. It was actually in process for about 4 years, basically being refined. And coincidentally, when it was beta tested and proven to be a reasonable alternative to a patient, COVID happened. So basically we were ready to start offering that exam in lieu of the patient. But as Joe was saying, the map that you're looking at here is there are 51 licensure jurisdictions in the country. And as Joe explained, basically the exam and what's on the exam is determined by statute. So the reason that you may have to have a periodontal exam on a patient is because it's in the statute. So if the statute doesn't change, that has to be offered in the exam. But there are 51 licensed jurisdictions in the United States, 50 states, plus the District of Columbia. So as Joe had said, right now as we speak, 41 of those jurisdictions will accept the non-patient CompeDont exam. And as he said, there are 2 states out of the 51 jurisdictions that don't accept an exam period. And he already said New York, which is PGY1, and Delaware, which has got their own patient-based exam, plus they require residency. Next slide, please. Basically, why is there an exam? And my good friend Guy Champagne loves this because this is the Guy's report, spelled differently, G-I-E-S. And Michelle should know that Dr. Guys was one of the founding doctors at Columbia University. So, and they give the Guys Award annually to different dental schools for excellence in dentistry. But basically, if you read in purple, what Dr. Guy is saying is that it's imperative that a dental practitioner have all the knowledge and skills to provide dental treatment to his patients. But even if he knew all about dentistry, but was not able to actually do it, then it would be unethical and unacceptable to give that person a license to treat patients. So that in essence is the reason why there's a cyclomotor hands-on component to licensure exams. Next slide, please. So basically, and some of what I'm going to talk about, Guy is the expert. This is his slideshow, and I'm just reporting on it. But basically, what this slide is saying is they did a study. This was written by the Nurse Education Today, and they did a study that kind of is comparing an OSCE, a non-hands-on exam, or somebody who just had clinical knowledge and self-confidence that they knew what to do. And they looked at how their performance was compared to a actual skills psychomotor exam. And the second bullet point there says the study did not provide evidence to support the validity of a knowledge test and self-confidence measures for predicting clinical performance. Most importantly, it revealed potential danger of a simulation-based assessment that could lead towards overestimation of self-confidence. So essentially what they're saying is because you think you know what to do, it doesn't mean that you actually can do it. Next slide, please. So again, if you're the patient sitting in the chair, the only thing that matters to you is that at the end of the procedure, it was a successful procedure. So again, the point of Dr. Guys, it's not enough that you know how, but you have to be able to do. Next slide, please. So basically, why did the CompeDont tooth, what it took so long? Because before the CompeDont tooth, the goal was to have something that was going to be either equivalent or superior to a plastic tooth that they had in the past. And basically, there's a whole list of deficiencies of the tooth before the CompeDont tooth. Caries wasn't discrete. There was an abrupt change from caries to healthy tooth. There was no tug back. There was no variability. It didn't follow the normal pathway of caries penetrating to the DEJ. And then when it gets to the softer dentin, basically mushrooms out. You can't see the difference between caries and affected or sclerotic dentin. Enamel on the plastic tooth was basically just much softer than real enamel. And so you also couldn't finish and polish finish restoration. Next slide. And this summarizes again, you can see the existing teeth on the market were all thumbs down and the CompeDont tooth is all thumbs up. Next slide, please. So basically, here's the issue. The top 2 bullet points are really of concern to you as students, because even now, after the COVID in the spring of 2020, we're starting to see the same thing with basically the fact that COVID is spiking again. The schools are working at, some of them up to 50% of normal capacity. So you are not getting the clinical experience that you really need to be getting. So that's of interest to a concern to you. But what's also a concern to state dental boards is there's a pressure on schools to still graduate dental students, and that they haven't had the same clinical experience of previous candidates graduating. Next slide. And you saw this before, there's 5 components. The only point that I would like to make here is the DLRC, which the ADA is behind. The ADEX exam has had an OSCE for 52 years. It's part of the exam, but it was felt that an OSCE in and of itself, for the reasons that I just said, is insufficient. So there are the other 4 components. The first 2 were the endo-pros were a non-patient based exam, and the perio-scaling and the restorative were on patients. Now we've changed that those are also available as non-patient. Next slide, please. So this is the CompeDont tooth, and I think you all want to hear about that. So basically, that's what the tooth would look like. Next slide. This is like one of the initial, ideal preparations. And if you look towards the gingival, like you can see the enamel as you go towards the distal, you can see the enamel changes, and you have like, this is basically a triphasic tooth. There's a pulp, there's dentin, and then there's enamel. So after you have the initial preparation and you fill that with an explorer, that area down towards the gingival part of that prep is the caries. Next slide. And this is actually showing that explorer is not being held by a hand. That explorer is stuck in the caries, and it's supported by the fact that the caries is sticky. And as you remove the explorer, you have the sensation of tug back. So on the ADEX exam and the CompeDont tooth, caries is defined as, it's defined as has tug back. It's not by color, and it's not by how soft it is, it's tug back. So next slide, please. So again, this is an example. You can see there's a discrete line between the dentin and the enamel. Next. There's another example of caries down towards the gingival facial. Next. Sclerotic dentin, but that, next slide. On the previous slide, what I meant to say is that sclerotic dentin is hard. So by definition, that would not need to be removed. That's hard, it's not caries. This is a finished prep. Next. Finished prep. Those are examples again of preps on other teeth. Next. And that's the finished product. So you can restore the tooth and polish the tooth. In fact, this is like the original generation. The enamel has even been improved a little bit more. So you don't see, you can obviously see where it was polished to the point where even the enamel was polished a little bit. The new CompeDont tooth is even, the enamel is even much better than what you see in this picture. Next, please. Again, examples of overextension. So without going into a lot of detail, the way the exam is run, it's a patient exam without a patient. Okay, so you go through all the same processes. The difference when you check it in, if you had a patient, you'd have a medical history, you'd have a consent form, you would have an x-ray of that tooth, and that patient would have to be, after the blood pressure was taken, sent to have the lesion accepted. Well, in the CompeDont, all of that is eliminated because all of the lesions are essentially the same. You know which tooth you're going to work on, and you go initially to the prep. Once the preparation is done to an acceptable or an ideal level, you now evaluate your prep and see if there is decay remaining that needs to be modified. And you submit that to the evaluation station. You fill out the modification request form specifying where you need to extend your prep beyond ideal to remove decay. If it's justified and your prep is graded as acceptable, even though it is beyond the ideal because it was recognized that it needed to be removed, and you use clinical judgment. Next. Now here's an example of an exposure. Now, because this is not a person, the pulp does not bleed. It doesn't have a red stain. That will be coming. It will probably have a gel type consistency. It will be red. It's more analogous to a necrotic pulp. When you get into it, it's essentially like a black hole. But this candidate, when they prepared the tooth, if they had stopped and saw it was getting black and they realized that it was hard, so it's not decay by definition, they could have stopped and asked for a indirect pulp cap, okay, which is appropriate on a patient. Exposing the pulp has a less prognosis for that patient than if you stopped and did an indirect pulp cap. So again, this is a patient exam without the patient. This candidate should have stopped and gone into the modification and said, I need to stop and I would like to do an indirect pulp cap. Next, please. These are examples of the number 30, class 2. This is, again, this person has an exposure. This was sent to the grading area if they had recognized that they had an exposure after having modifications approved. This would not necessarily be a critical error and a failure. They would have been allowed to put a direct pulp cap because they Caries exposed the pulp. But this is somebody who sent it in for grading and didn't even recognize that they were in the pulp. Next, please. Again, a similar example, and you can see on the picture from the occlusal how much overextended from an ideal the axial wall is. Next, please. Again, this picture, if you look at the adjacent tooth, there's adjacent tooth damage. So people had adjacent tooth damage, which could be a critical error if it's something beyond what could be polished off. Go ahead, next. Again, caries remaining. Next. Here again, this is somebody who sent in there. This is a caries remaining. Next. And the same thing. Next. Okay, you're getting the picture. Next. Next. All right, so here's the point. The critical errors on the CompeDont tooth were essentially confirmed by the pilot study to be the same type of errors that you would make on a patient. So they had unstained caries. Students were looking for something that was discolored. Unstained caries with hugback is caries. So people were looking for color. They were missing that there was still caries and submitted it. They had stained caries, as I showed you in the pictures. When they restored the tooth, it had a visually open contact. They had debonded restorations. They had irregular contacts, over-prepared, even worked on the wrong tooth, and they had modification errors. So for example, if you submit a modification request and you haven't gone to at least an acceptable level, your prep could be, your exam could be stopped for a complete lack of clinical knowledge or judgment. You should know what an acceptable level preparation is. You're into the dentin and you're into the decay. And so that, again, they had gone, they're all in enamel. They hadn't even accessed the decay yet. Next, please. Okay. What are the advantages of this examination? As Joe alluded to before, on a patient-based exam, you would select your own patient. So it was in your best interest to find something that qualified, but was basically as simple as possible. So what we found was there were a lot of lesions that were accepted because they met the minimal criteria that when the ideal prep was done, they had no reason for modifications because they had removed all the decay. This tooth has been designed so that every tooth has the same level of decay and challenges you beyond an ideal preparation. You will more than likely need modifications. All right. You can't pick a lesion that you've shown to the faculty and discussed how you're going to treat that lesion. Basically, you're going to see it on the exam and going to be said, this is the tooth you're going to work on. And you're able to test the skills, knowledge, and judgment that subject matter experts have chosen to determine the extent and type of lesions for the tooth. Next. Again, modifications are required by everybody, and you can't pick a lesion that's so small. And you don't have to worry about trying to recruit a patient, trying to compensate a patient in some cases with an exorbitant amount of money. You don't have to worry about the patient not showing up. And you don't have to worry about, from a patient's point of view, a tooth that ends up with a pulp exposure that really was an unjustified iatrogenic exposure. Next, please. Okay, we piloted this exam with about 600 students at different schools. I believe, Joe, your school was one of them. Indiana, Midwestern Arizona, Midwestern Chicago. I can't remember, Detroit Mercy. So there are approximately 600 students that took that exam. And we used about half of the examiners grading were faculty. And the reason we wanted that was we wanted the input of experienced dentists as well as entry-level dentists. So it's hard to read. The graph is a little bit small. The top two are people who either agree strongly or agree. The middle is neutral. The lower is disagree, and the lowest is strongly disagree. And they asked different questions. The first question was, and I'm having trouble reading it myself, did the simulated decay seem like decay in a patient's tooth? And more than almost 2/3 of the respondents, whether they were a dentist or the student, agreed or strongly agreed. The rest of the people were mostly uncommitted. Did the simulated decay feel like decay? Was it sticky? Did it have tug back? And again, most of the people either strongly agreed, or were ambivalent. And then were the candidates able to finish polish? And again, it was pretty much unanimous. And in fact, the people who were more ambivalent, that either disagreed or thought there was no difference, most of those were students. The faculty and examiners all were, they agreed strongly or agreed. Next, please. Again, this is a bar graph that summarizes the same thing more in a percentage. You can see like over 85% said that they thought this would be a good substitute for the patient-based exam. Next. So here's the study results next, and I'll try to quickly go through this. Basically, what they needed to know is when you do a study, you have to decide, is the mode basically a reasonable replacement for the tooth in this case? So does it look like a tooth? Does it feel like a tooth? And then does the outcome support the fact that the study was valid? So did the reason people failed the exam coincide with the reasons they would fail on the patient exam? Next. And so again, most frequently confirmed errors were the same, whether it was the patient or on the CompeDont tooth. Next. So here's really the proof of the pudding here. Candidates who had one or more modifications granted had a higher pass rate. The highest pass rate was observed for those who had all of their modifications granted. So essentially, these were people who looked at the CompeDont tooth after they were at an acceptable level, knew that they had to make it bigger because they had decay. They asked for it correctly, and their judgment was confirmed, and they went ahead and did it. They had the highest pass rate. Candidates who had no modifications, or they had modifications that were requested and denied, had a lower pass rate. So therefore, the judgment was a critical factor in being successful on the exam. But judgment was not the only critical factor, because there were some candidates who had all their modifications granted, but they still failed the exam because after doing the modifications, they may have been looking for discolored caries and it wasn't discolored and they left decay, or they went beyond removing the decay and ended up with an exposure. So judgment, again, does not predict psychomotor skills. Next, please. So the conclusions are the CompeDont tooth identifies the same critical deficiencies. It affirmatively requires the candidate to identify caries. The pass rates, like I just said, I think it's a better exam. I think Dr. Gambacorta would agree, because it's a more equitable exam. You have the person next to you doesn't have an incipient lesion, and the person on the other side of you has a tooth the decay. The x-ray looked like it was going to be an ideal case, and all of a sudden it's you're worried about a pulp exposure. So basically, I think that supports the reasons for the exam, the CompeDont tooth replacing the exam. And just as a last, I don't have a slide that says this, but the data that before COVID, the CDCA had done about 2,600 patient exams before schools shut down for COVID. And then after we started recycling to give the exam, we did around 1,000 on the CompeDont. So some students, even at the same schools, because of the CIF format, some students at a school had already taken the patient exam. The other people in their class were taking it on the CompeDont. The pass rate on the patient-based exam, anterior, posterior, approximately 94%. Pass rate on the CompeDont tooth, anterior, posterior, approximately 94% for the same reason. So I think you can feel comfortable that you will be getting a fair and an equitable exam on a non-patient. And I think next slide, I think that's it. So thank you very much. I hope I didn't use too much time, but both Dr. Gambacorta and myself will be happy to answer questions. And I gotta put this thing back on so I can hear you.
Thank you so much, both Dr. Gamba and Dr. Perkins, and thank you for also answering some of the questions in the chat. So Dr. Gambacorta, if you want to start off speaking on the Buffalo Sith.
Sure. So you and the Buffalo, the CIF, you want me to talk about that? Oh, sure. Okay. So the CIF really, as I mentioned a little bit briefly in the presentation, the CIF, the major factor is it's the exam is completed on a patient of record and the procedures are found within a treatment plan that the patient already has as part of what's going on. One of the really big things for the CIF is that say if a student is unsuccessful, so for example, the student has caries remaining, and that when the patient goes back to the grading area, caries is remaining and the student feels or the candidate feels they're ready to restore that tooth. What would happen at Buffalo, we would then work with the student with faculty on the floor. We would discuss the failure with the student, but then we would excavate the remaining caries and the patient would have the tooth restored as they would normally if they were having a regular appointment in our clinic. And so this really helped in really the ethical treatment of patients, because in a lot of cases, so when I took the board, if you pulped out or you had a failure, you weren't allowed to continue. You would put a ZOE temporary in or something like that, and then the patient would have to return and come back for work. But with this, we were able to allow the students to finish it. The patient will walk away with what they started. Another thing that was really beneficial, especially to the students, is we allowed them to challenge competency exams within the curriculum during the licensure exam. So if you were doing your class 2 during the licensure exam at the CIF, that would also count for your class 2 during, say, your restorative requirement. And one of the things, we had faculty on the clinic floor that were looking and examining these patients in addition to the CDCA examiners that were coming to the dental school. We also, all of the work went as part of the patient's electronic health record. So all of the entries, even before we had a completely electronic system at UB, we had a patient record and a part digital. Everything was documented so that 2 years, 3 years down the road, all of a sudden, if that patient had a problem with number 28DO, they would have known, well, that tooth was done during the May ADEX in 2018. And before, we never really documented in that way. So it really, for me anyway, it was one of the best parts about doing the licensure exam, was that the way of combining so many different aspects of the curriculum requirements, making sure the patient's left with restorations, even though there was a failure. If a student, if we needed to initiate endodontic treatment for some reason, there was an exposure, we would bring an endodontic coverage up from one of the floors. They would then supervise the initiation of endodontic treatment so that the patient could leave with a pulpectomy, pulpotomy before they had to come back for their next appointment. So Dr. Perkins was one of the dentists integrally involved in the development and moving that along. I know schools are still running that model, but now obviously, as you see during the map, all but 4 or 5 states are accepting the mannequin-based typodont exam for licensure. But yet, as of right now, I think I have about 21 students in the class of 21 that still need, they're going to one of those states that want to take the patient-based exam. And I know some students are taking it just in case they feel they have to move and they want to move. Now, there's a question in there about a national licensure exam. And Dr. Perkins certainly comment too. ADEX is really, that's what the goal of ADEX has always been, create a national exam that's universally accepted. And I think too, from looking at the map, we're very close to doing that.
Thank you so much for expanding on that.
Can you hear me?
Yes.
All right. I think to really completely explain the difference. You have to understand the way it used to be. When Joe and I took our exam, basically my exam was taken in May and you graduated. So if your patient didn't show up or you failed a part of the exam, you weren't taking that exam again until August. And more than likely you were traveling to a different place. The other bad thing, which Joe alluded to, is some people, instead of using a patient of record at the school, would find somebody who would come in, maybe a relative or maybe a friend who would come in. And let's say hypothetically, they had a problem with that tooth. The exam was on a Saturday, and Monday morning, that tooth is bothering them, and they show up at Joe's clinic and say, this tooth is killing me. And I had it done yesterday on the exam. And Dr. Gambacorta says, well, who are you? I have no idea what was done. I have no record of anything that was done. And now it's my problem. So basically, the other big thing about the curriculum integrated format was that exam was offered at a school maybe 5 times beginning in January. So at some schools, we were, depending on the size of the school and how many students they had, we might be there January, February, March, April, and maybe even in May. So here's the point. You had 3 procedures that had to be done on a patient, anterior, posterior, and perio. But you only had 2 patients. Or at the end of the day, you realize you didn't have time to attempt that 3rd procedure and be able to do a good job. Well, you could opt out, complete 2, and then when we were there in February, you could have that 3rd patient come in and complete that. So basically, by the time of graduation, most students had finished all 3 parts of the clinical exam on a patient by the time they graduated. And you didn't have all of that other crazy nonsense. So the CIF was a big leap forward from what Joe referred to as the traditional format, which is what we took, and that's what people took the exam on before the CIF. The CompeDont and non-patient exam has really alleviated the need to do that because all of the patients are there, and you eliminated the time of lesion acceptance and all of that. So the amount of time available is really more than adequate.
Thank you, Dr. Perkins. As the last question for the day, there were a few people who were asking about the mannequin-based perio exam, if you can expand on that.
Okay. Basically, again, to go back, what is the difference? On the patient perio exam, you would have to find a patient that had on it no more than 6 to 8 teeth, 12 surfaces of subgingival calculus to qualify. And then you would submit that patient after they had their medical history and blood pressure and everything accepted. They would actually go in for pre-treatment evaluation to make sure that those 12 surfaces of calculus were there. So there were a small but real number of candidates whose patients didn't have 12 surfaces. If they had only 8 surfaces of calculus, you failed the exam. You were not allowed to start because you had already had basically 4 errors in removal because the calculus wasn't there. So you've eliminated that. Now what happens is you come in and you had 90 minutes of treatment to remove those surfaces of calculus and send a patient in for a post-treatment evaluation. Now what's going to happen is you will be given a mandibular typodont, and the typodont will either say, it'll have a form that comes with it, yellow or green, that will be either for the left side or the right side. And the surfaces of calculus that you will be assigned to remove are going to be on that form. And you will have 90 minutes to remove the calculus on those surfaces. And then you submit the typodont in to be graded for calculus removal. So basically, it's a much simpler exam. There is no penalty for calculus detection because it's there. And the basic failure is because you did not remove calculus from 4 more surfaces of teeth. And that's essentially it.
Thank you so much. Thank you both to Dr. Perkins and Dr. Gambacorta for sharing time on your Saturday, especially during the playoffs and during.
Hey, we're winning 14-10, so it's a bonus.
Got to support the District 2 football teams too. So
thank you very much for letting me participate.
Yeah, thanks a lot, you guys. Have a good weekend. Enjoy your time together.
Thank you.
Bye-bye.
For all the students still on, Alyssa is quickly going to share the launch code. And just as a reminder, so it's space, we will be joining tomorrow directly into our tracks. So professional development, wellness, or advocacy at 9 o'clock Eastern. So we will see you then. Thank you for joining.